Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 11th episode of Optometry Series 2.2. I'm very happy to welcome my team members, Ms. Meenakshi and Ms. Anshika, ma'am. Hi, both of you. Thank you so much for joining. Over to the MC. I would like to request Ms. Sharmila to introduce the moderator.
Good evening, everyone. I am Sharmila, a third year Bachelor of Optometry student at Dr. Agarwal's Institute of Optometry, and it gives me great pleasure to welcome our moderator for the day, Mr. C. Nivedhitha. Ma'am is an assistant professor in the Department of Optometry at School of Allied Health Sciences, Vinayaga Missions Research Foundation, Chennai campuses. She pursued both the undergraduate and postgraduate studies at Sri Ramachandra Institute of Higher Education and Research in 2020, with 1 year of rich clinical experience and over 5 years of teaching expertise. She has contributed immensely to academics at MM School of Optometry and School of Allied Health Sciences, Vinayagar Missions Research Foundation, Salem and Chennai campuses. Her clinical interest lies in binocular vision, in which she also completed her postgraduate project, which later got published. Behind this, she has been inspiring mentor postgraduate students in their research journey. Which are truly happy to have you with, with us today as the moderator. Thank you so much for joining, ma'am. Now moving forward, the presenter for today's Ms. Athifa Anjum, a third year Bachelor of Optometry student at Dr. Raghuva's Institute of Optometry. Ms. Athifa, please start your presentation.
The topic is iris and ciliary body diseases. Okay. The anatomy of first, basically the anatomy of the iris. Recap. The iris is the anterior part of the uveal tract shaped like the thin circular disc similar to a camera diaphragm. Its central opening, the pupil, is about 4 mm in diameter. It controls light's entry to the retina. At periphery, the iris is attached to the middle of the anterior surface of the ciliary body and separates the space between the cornea and the lens into the anterior and the posterior chambers. The macroscopic structures of the uh, iris is ciliary zone and the pupillary zone. And then the microscopic structures are internal limiting membrane, iris stroma, anterior epithelial layer, and the posterior pigmented epithelial layer. Next, the ciliary body. Ciliary body forwards extension of choroid at ora serrata. Cross section is triangular in shape. Relations: anterior side forms part of angle between anterior and the posterior chambers. Iris attached at its middle. Outer side lies adjacent to sclera, separated by suprachoroidal space. Inner side has two distinct regions, pars placata and the pars plana. Pars placata, anterior folded region with ciliary processes. Pars plana, posterior smooth region. Microscopic structures of the ciliary body is supraciliary lamina, stroma of the ciliary body, layer of pigmented epithelium, layer of non-pigmented epithelium, internal limiting membrane. The diseases of iris and ciliary body are categorized into three types: congenital anomalies, inflammatory, and the tumors. Congenital anomaly of iris. Heterochromia of iris. It refers to variations in the iris color and its common congenital anomaly. Heterochromia iridum, colors of one iris differs from the other. Heterochromia iridis, one sector of the iris differs from the remainder of iris. Congenital heterochromia must be differentiated from the acquired heterochromia as seen in the heterochromic cyclitis, siderosis, Horner syndrome, and malignant melanoma of iris. Heterochromia of iris, there are two types: heterochromia iridum and the heterochromia iridis. Color of the iris differs from the other, and the heterochromia iridis is one sector portion of the iris differs from the remainder iris. As you can see in the picture, the first picture is the heterochromia iridum. Uh, the uh, 1 minute. The color of the iris is different from the other pupil. Other eye is the heterochromia iridum, and in the same eye, the iris color is divided into two, that is heterochromia iridis. uh, Correctopia, abnormal displacement of pupil from its central position, from its normal central position. There are two types, congenital and acquired, seen in conditions like Axenfeld-Rieger syndrome, ectopia lentis et pupillae, aniridia, or abnormal embryonic development. Acquired due to trauma, intraocular surgery, intraocular tumors, or extensive synechia formation. Polychoria presents more than one pupil in the same iris. The polychoria is divided into two types, true polychoria and the false polychoria. This is the iris abnormalities. Persistent pupillary membrane, remains of the embryonic tunica vascular lentis, vascular sheath of the lens. Appearance, thin stellate shaped shreds or strands of pigmented tissue arise from anterior surface of the iris, may be free floating in the anterior chamber or attached to the anterior surface of the lens. Clinical features are usually asymptomatic and discovered incidentally. In extensive cases, strands crossing the pupillary axis can reduce vision or cause amblyopia in children. This is the picture of the persistent pupillary membrane. Then congenital anomalies of coloboma, congenital anomalies of uveal tract, congenital coloboma, absence of tissue. That is iris, ciliary body, and may be seen in association or independently. Coloboma may be typical or atypical. Typical coloboma is seen in infronasal quadrant and occurs due to defective closure of the embryonic fissure. Typical coloboma may be complete or incomplete. Atypical coloboma is occasionally found in other positions. It is usually incomplete. Congenital aniridia. It refers to congenital absence of iris. True aniridia, complete absence, very rare. A clinical aniridia, peripheral iris rim present. Zonules and ciliary process often visible. The conditions is usually familial and may be associated with glaucoma due to angle anomalies. Inflammatory, anterior uveitis, iritis. In this condition, inflammation predominantly affects the iris. Iridocyclitis. In this condition, iris and pars peccata part of ciliary body are equally inflamed. Anterior cyclitis. In this condition, the pars placata part of ciliary body is predominantly affected. Etiology, infectious uveitis, bacterial uveitis, viral uveitis, fungal uveitis, parasitic uveitis, and rickettsial uveitis. Non-infectious uveitis, immune-related uveitis, uveitis in non-infection systemic diseases, toxic uveitis, traumatic uveitis, idiopathic uveitis. Masquerade syndrome, non-neoplastic masquerade syndrome, neoplastic masquerade syndrome. Symptoms are pain, redness, photophobia and blepharospasm, lacrimation or defective vision. Signs, lid edema, circumcorneal congestion. Corneal signs are corneal edema, keratitis precipitates, mutton fat capes, small and medium capes and fine capes, pigmented capes. Posterior corneal opacity. Anterior chamber signs are aqueous flare, aqueous cells, hypopyon, changes in depth and shape of the anterior chamber, changes in angle of the anterior chamber. Iris signs are loss of normal pattern, changes in iris color, iris nodules, posterior synechia, rubesis iridis. Pupillary sign are meiosis, irregular pupil shape, ectropion pupillae, pupillary reaction, occlusion pupillae. Lens signs, pigmented dispersal, exudates, complicated cataract. Vitreous and retina signs are exudates and inflammatory cells, cystoid macular edema. IOP changes are may be normal or increased or decreased. Differential diagnosis or acute congestive glaucoma, acute conjunctivitis. Investigations are hematological investigation, ESR, blood sugar level, blood uric acid, serological test for syphilis, urine examination, WBCs, pus cells or RBCs, and culture to rule UTI. Stool examination, cyst and ova to rule out parasitic infestation. Radiological investigations are X-ray, CT scan, MRI scan, skin test, biopsy or intraocular fluid sample examination, aqueous, vitreous, lungs, and lymph node biopsy. Treatment or local therapy is cycloplegic and mediatric drugs or corticosteroids. Systemic therapy, corticosteroids, NSAIDs, immunosuppressive drugs, antibiotics. Physical measures, hot fermentation, dog goggles. Treat the cause and treat the complications. Next, the tumors of the iris. Nevus. It is the most common lesions of the iris. It presents as flat, pigmented, circumscribed lesion of variable size. Rarely malignant change may occur in it, so it should be observed. Ne- Neovax Neovaxotoendothelioma. It is a rare fleshy vascular lesion seen in babies. It may cause recurrent hyphema. It is treated with X-rays or steroids. Malignant melanoma. It presents as a single or multiple rapidly growing vascular nodules. It spreads in the angle producing secondary glaucoma. It may penetrate through limbus and present as epibulbar mass. Pathological features are similar to that of melanoma of choroid. Treatment: wide eye reductomy. It is performed for a tumor limited to the iris. Iridocyclotomy. It is required for tumor involving iris and ciliary body. Enucleation. It should be performed when iris melanoma is associated with secondary glaucoma. Tumors of ciliary body, hyperplasia and benign cyst. These are insignificant lesions of the ciliary body. Medulloepithelioma. It is a rare congenital tumor arising from the non-pigmented epithelium of the ciliary body. It presents in the first decade of life. Malignant melanoma. In the ciliary body, it is usually diagnosed very late due to its hidden location. It may extend anteriorly, posteriorly, or grow circumferentially. Clinical features. Earliest features of a localized melanoma include slight hypotony, unaccountable defective vision, unlocalized sentinel, dilated episcleral veins in the quadrant containing tumor. An anterior spreading tumor may present as follows. It may cause pressure on the lens resulting in the anterior displacement, subluxation, and cataract formation. It may involve iris and is visible immediately. Soon it may involve the angle of anterior chamber resulting in secondary glaucoma. It may extend out through sclera along the vessels, presenting as an epibulbar mass. Posterior spreading tumor may involve choroid and present as exudative retinal detachment. The tumor may extend circumferentially, involve whole of the ciliary body. The treatments are enucleation. It is required for large ciliary body tumors extending anteriorly, posteriorly, or circumferentially. Local resection, cyclotomy or iridocyclotomy may be enough. It fortunately, tumor is detected in early stage. Thank you.
Very crisp and elaborative presentation. Now I request our moderator ma'am to add your valuable inputs, ma'am. And sorry for the delay from our side.
Okay, that was a very good presentation with a brief note on iris and ciliary body diseases. I just want to add a note on one more disease is called um, intraoperative floppy iris syndrome. It is one of the complication of the cataract where the iris will become extremely soft, floppy, and during this surgery, the iris may get prolapse. So the patient will end up with prolapsed iris. So the main cause of this floppy iris syndrome is medication taking for certain systemic disease like enlargement of the prostate gland. These medication will block the alpha adrenergic antagonist in the iris dilating muscle, so that it will leads to loss of muscle tone and the floppy iris. So to avoid this, with a detailed history of medication and systemic disease, help to do prophylaxis before the cataract surgery, like stopping the medication before the surgery, or using iris hoop to hold the iris in place during the surgery may help to avoid this intraoperative floppy iris syndrome complication. And so that was I want to add as one more disease for this iris and ciliary muscle. And overall, I just want to give a clinical input for iris and ciliary body diseases. Um, Patient will usually come with a complaint of visual changes and redness and pain. And while you see for the pupil irregularities, there will be a synechiae like posterior or anterior synechiae, which may lead to the complication of the glaucoma. So there will be increased in intraocular pressure. So you can see that sign or sign in the patient while they are coming. And when we are doing the slit lamp examination, if you see the anterior chamber with aqueous flare and cells, it is the hallmark sign of the uveitis. And you also will see for the synechia, as I said before, it will lead to intraocular pressure, increase in intraocular pressure, so that it will lead to secondary glaucoma. And other irregularities like keratoopia, atrophy of the iris, and aniridia. These changes can be viewed in the slit lamp examination. So, by differentiating the signs and symptoms, it will be easy for us to do differential diagnosis in the clinical side. So, that's what I want to summarize for this session. Thank you. And finally, I thank this team for inviting me as a moderator. I feel pleasure to be moderator for this session, and it is a wonderful job that you team make, encouraging the students to do in the social media. So I hope you continue this work for the benefits of the students. Thank you.
Thank you so much, ma'am. It was a very crisp and key points where we have to look for in iris and ciliary body issues. From the student's perspective, there is one question alone, ma'am. What
Okay.
could be the role of Optum in diagnosing iris and ciliary body issues or as such uveal issues?
That's what I discussed before. Uh, First, is detailed history is very important because it relates to some systemic disease also, like in case of uveitis, rheumatoid arthritis, or some other systemic disease will be involved. So, detailed history taking is very important along with the symptoms of the patient, visual changes, what are the visual changes they are experiencing, and while looking at the patient, you will see the iris changes also. If the patient comes with aniridiana, you will know that there is an absence of iris. Correctopia also, it will be visible while seeing. So that is the key points for the optometrist in the first. Then while doing the comprehensive examination, as I said, slit lamp examination, you will be easily able to diagnose the disease. Whether if there is a uveitis, now there will be a aqueous cells and flare cells, and the iris will be muddy light in color than usual in case of iris changes. And you can see Cope's nodule and Busaka nodules in uveitis also. So, and in case of synechia, there will be a posterior attached to the cornea and posterior attached to the lens and anterior attached to the cornea. You can see synechia. These changes will be able, while seeing the slit lamp, will be able to diagnose the iris disease easily. Thank you.
Thank you so much, ma'am. Yeah, thank you so much, ma'am.
Thank you so much, Meenakshi. Nivedhitha, ma'am, thank you so much for joining us as the moderator for the day, ma'am. Thank you so much.
Okay.
Audiences, thank you so much for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your optometry friends. We'll meet you in the next episode. Thank you. Thank you, ma'am.